Welcome to our Thursday broadcast. Today is April 9th, and my name is Deborah Volosin, and I'm joined today by Cahuilla Delta CEO Gary Herbst, and we're going to be asking questions that have come in either from our community groups or online. And so, Gary, thank you so much for joining me today. I know you're very busy, so we appreciate your time. So let's go ahead and start with just the basic information that people want to know. How many positive patients are in Tulare County? How many are currently inpatients in Cahuilla Delta? And, the county gives out the number of people who have died, but if you want to cover that as well as maybe giving us an update on people who have recovered.
Great. Okay. Thank you, Deborah. And thanks for having me back. Good to be with all of you virtually. We definitely want you to be well informed and up to date and understand everything that's going on in our community and what's going on at Cahuilla Delta. So thanks for tuning in. Let me start kind of at a higher level. I'll start at the state level. A publication I received just yesterday, the state reported that statewide we've now conducted 169,000 COVID-19 tests. 154,000 of those 169, the results have come back. We still have about 14,000 tests that were still pending results. So of the 155,000 that have come back, roughly 17,000 have tested positive. All the rest have tested negative, which is obviously still the vast majority of them. And sadly, of the 17,000 that tested positive, we've had 442 deaths statewide. And again, this was as of Tuesday. So now bringing that down to more local to our county, the county reported yesterday that they have 168 positive cases throughout Tulare County. As you might expect, just because of population density, that more than half of those cases are in Visalia. In fact, 58% of the 168 or 98 patients living in Visalia, or people living in Visalia, have tested positive. And of those that have tested positive, unfortunately 7 have passed away. That was the report as of probably last night. Unfortunately, I was in the command center here at Cahuilla Delta earlier this morning and learned that an 8th patient has passed away. It's the 5th patient at Cahuilla Delta. So the county also has reported that 9 people have recovered, but it continues to monitor about 271 people that are self-quarantined, but are in frequent contact with the county, monitoring their temperature and other indications of symptoms. We actually have had 4 of our patients that had been hospitalized that have recovered and have been discharged home, so that's very good news. We also obviously are keeping close tabs on our healthcare workers too, and making certain that we're keeping them safe. As of April 7th, again 2 days ago, the state reported that just shy of 1,700 healthcare workers have tested positive for the virus. At Cahuilla Delta, we've had 7 employees, so that's pretty good, 5,000 employees, although we have several hundred now that are working from home. But 5,000 employees, and as of yesterday, 7 have tested positive for the virus. We currently, right now, have 20 patients that are in the hospital that are in for known coronavirus or suspected. Of the 20, 12 have tested positive. About 5 of them are in the ICU, and the other 7 are on 2 South, which is our designated COVID unit, or where we put patients that we suspect may have it. And then 8 of the 20, we're still waiting on results from them. To date, Cahuilla Delta has collected now 1,220 specimens that really started back in March. So March and April we saw, or obviously April, the bulk of it. So 1,220, of which 94 have tested positive. I generally share with you the age distribution of those positive tests. 7 of them in people younger than 20 years old. The vast majority tend to be in the younger population that are testing positive, so say 20 to 40 years old. We've had 41 of the 94 in that age group, another 26 in the 40 to 60 age group, and 20 of the 94 older than 60 years old. I think I'll leave it there.
Okay, so is Tulare County testing more people in surrounding counties? Is that part of the reason why we have so many positive tests compared to like Fresno County? Is that an issue, or is that?
Tulare County was initially named as the regional testing site for the Central Valley. So Fresno County, when they would collect specimens, would send them to Tulare County for testing. So it's possible, and I think I might have addressed this last week, because people were curious, as am I, is how could, Tulare County, which has about half the population as Fresno County, how could we have so many more cases? Mm-hmm. And I think it was primarily because we started testing a lot earlier in Tulare County. And I believe that Tulare County has been, initially was giving preference to Tulare County hospitals in terms of quickly turning around those results. But since that time, many hospitals now have developed testing capability within their own hospitals. So I think you will continue to see Fresno County's numbers increasing as they have greater testing capability within their own county. I do have in front of me here, and I mentioned Kathy Whitman, who's our infection prevention manager, puts out this COVID-19 daily dashboard. And of the 1,220 specimens that we've collected, almost all of them have come from patients that are living in Tulare County. We actually have tested patients that actually live in other counties, Fresno, Kern, Kings, that just happened to be in Tulare County when they became symptomatic. So they did come to us and we collected tests. So I guess technically we are testing people that live outside the county. But I don't think that's really what's affecting the positive rates, the disparate rates that we're seeing.
So the Redwood Springs, that's just kind of taken us all aback. But so are there other nursing homes being inspected in light of Redwood Springs? And I know sometimes those employees work at multiple skilled nursing facilities. So are they taking extra precautions, or are you in communication with them at all?
We do stay in frequent communication with the various nursing homes. In fact, we actually meet with them every single quarter. But since that breakout at Redwood Springs, we are staying in more constant communication. I believe that they all have significantly ramped up their precautions that they're taking and providing their staff with appropriate personal protective equipment. I'm definitely monitoring their patients more closely. I do believe that we received a patient from Casa Grande nursing home that did come to us. But my recollection is that patient actually tested negative. Of those 60 Redwood Springs patients, only a few, maybe 3, actually ended up being admitted to Cahuilla Delta. So they are being quarantined or cohorted together at Redwood Springs, being taken care of staff that have all the PPE necessary to take care of them well. But that's always the greatest fear, is that when you have people living, so many people living in kind of a confined area, and particularly that this tends to be an elderly population, many of them having underlying health conditions. It definitely makes them more susceptible. I mean, that's what we saw up in Washington State. Really, the first outbreak was up there, and that's where they had the highest number of deaths, was in a nursing home. So we have to pay very close attention to them.
So this next question is going to kind of ask you to use your magic 8 ball. So the question is, when do you expect that rates of new cases will start to fall off? So that question can also be, when do you think the surge is going to happen?
Right. So that's an excellent question, and you're right, it does take a crystal ball, and those predictions are changing, if not every day, at least every week. I was on a call last week with all the CEOs up and down the county, or up and down the San Joaquin Valley, from Kern County all the way to Merced County, and we were hearing that the predictive models that they were using at the time were suggesting that we were going to really start to see the beginning of the surge. It would start in the Bay Area, then it'd move quickly to Southern California, and they were actually projecting that it would start this last weekend. But because of, I think, the measures that California took very early with respect to social distancing, sheltering in place, closing down so many different venues where people gather, that it actually has had the effect of flattening the curve. So they now pushed that beginning of the surge to mid-April. So that's the beginning, not the apex. And then because of the San Joaquin Valley being less densely populated than these other areas, predicting that we were probably 1 to 2 weeks behind the Bay Area and Southern California, so that it was more likely that we would be beginning to see the local surge here at the end of the month or the 1st of May. The governor actually stated recently that he's predicting that we will see the apex in California around mid-May. Now that all said, and I think this is one of the things that's very frustrating to us in healthcare and trying to plan for the unknown, there is a highly reputed, highly endorsed predictive analytical tool called COVID-19 Qventus. And I think anybody can go online and look at it. And you can actually plug into it specific regions to see what the models are predicting for that particular region. So we've been looking at this tool over the last few days, and for whatever reason, Tulare County is joined with Kern County in defining what our particular South Valley region is. The population of the two counties, Kern and Tulare, is 1.4 million. And so what their model is showing is that for that particular region, Kern and Tulare County, that the surge will begin around the 1st of May, but that it would not peak until mid-July, which is very disconcerting because obviously that's 3 months from now. And the thought of sustaining the effort that has been going on for this last month for 3 more months until we hit the apex, you start losing a bit of your optimism at that point. But so that's again the frustrating part is we don't know exactly when that's going to happen. We do hear that the outbreak, the rate of new cases on the East Coast appears to be declining. The mortality rate appears to be declining. I think Governor Cuomo is suggesting that they might be reaching a plateau, which is great news. But just I'm hoping that California and the San Joaquin Valley in particular, that it would be a much different experience that we have here than what they've had in other places of the country.
So is Cahuilla Delta providing more than supportive therapy for our COVID-19 patients?
Yes, about probably 2 weeks ago when we had our first patient that was really struggling in the ICU, was intubated, had actually been a patient for, I would imagine, more than 2 weeks. Ultimately, she did pass away, but we began using a combination of hydroxychloroquine and azithromycin. Those two drugs together are being used in what they call compassionate care situations. They certainly were never designed to try to treat the COVID-19 virus. They were designed to treat other viruses, but they have proven to be fairly successful in the treatment of COVID. So there are a number of studies that are underway right now to determine the efficacy of these two drugs together, as well as other therapies that have been pursued. One of the most promising right now, and you've probably been hearing about a blood test that is actually, it already exists. I was listening to the news last night, and it's been available in Germany now for more than 3 weeks. And it's a blood test that detects the antibodies in somebody that had been infected with the virus but has now been essentially cured. So they are now virus-free, but their body then develops the antibodies. And that those antibodies are in our bloodstream. They actually then will extract the plasma that our red blood cells flow through, but to actually extract the plasma from those cured COVID patients and inject it into patients that are sick, really hospital patients that are in the ICU, that are intubated, and then with the hope of those antibodies now attacking the virus and potentially curing them as well. So that is probably one of the most exciting developments that we're hearing about right now, and the fact that it already exists. And this type of therapy has been used in the past, but obviously this is a new virus, so we don't know yet if it's going to be effective. But it definitely appears to be promising.
So if a patient tested positive for COVID and they have fought and recovered, is it possible for them to contract it again?
Well, that's one of the unknowns, because obviously we think about the flu. The flu is a virus. It's a seasonal virus. There is a vaccination for it, but in any given year, it's probably about 40% effective in actually preventing you from contracting the virus. But that said, those that do get the vaccination and still contract the flu, that generally the symptoms, the reaction to it are much more mild. And we have antiviral medications that if given very early in the onset of the flu, that they can greatly shorten the life of that condition. But you do know that every year we have to get vaccinated over and over again. Each year we get vaccinated because you're not immune. Once you get the flu, it doesn't mean you're immune the next year from it. So with respect to the COVID virus, though, the whole discussion around if you get it and your body develops the antibodies to fight it, will that make you immune for the rest of this season? Again, we don't even know if this is going to be a seasonal virus like the flu. But just the whole discussion around antibodies would suggest that once you've had it, that you wouldn't get it again during the same time period. But who knows what will happen next year. So that's, obviously there's a tremendous amount of study and research that's going on right now. Bless all the scientists across the world that we have some incredibly smart, talented people that are very dedicated to trying to help us as quickly as they can.
Are there any vaccines close to being ready?
Again, my knowledge is probably the same as everybody else. It's what I'm, reading in the paper. I do have the benefit of being able to talk to Dr. Boken, our epidemiologist, and yes, those scientists and across the world are working very diligently on developing a vaccine, and I believe that they already are testing those vaccines in laboratory animals, but that still creates a pretty wide chasm between animal testing and actually giving it to humans. So everything I've heard is that it would probably be at the earliest late summer before a vaccine would actually be mass produced and be able to given to people. More likely it's going to be later than that. But that's, again, one of the concerns. The flu starts arriving in October. And so, is this virus going to kind of behave similarly so that, and we usually get vaccinated for the flu right around the 1st of October, and it will last us into March. So having a COVID vaccine by October might be more realistic.
Is the hospital participating in any research studies directly associated with the development of a vaccine?
No, not at this time. Certainly if we were asked to participate, I don't know why we wouldn't. We're a teaching hospital. We actually have a formal office of research that's led by Dr. Chris Patty. In fact, Dr. Patty is a member of our leadership team, and he described a voluntary research study that is underway that he actually personally enrolled in, and I guess anybody can enroll in it, and he was encouraging many of us at Cahuilla Delta to enroll in it. But it essentially wants to track just people and whether they contract the virus or not, what medications they take, how did it affect them, to really kind of build a strong database on around just the characteristics of the virus and what people did to combat it and deal with it. So, but it's not something that is sponsored through Cahuilla Delta.
What are employees and physicians doing to protect their families during this time?
Well, the first thing they do is we protect them here at work. So when they leave their families and come to work here, we make certain that they all have the personal protective equipment that they need when they're taking care of patients. And again, that really varies from where you are. If you're in the ICU or you're in the operating room or the cath lab or in the emergency department, are you taking care of a patient that's tested positive for COVID or suspected? Are you doing a procedure that could cause the virus to become aerosolized? So when you're intubating a patient or doing a breathing, you're going to wear a lot different PPE than if you're going into a patient room that they've tested negative or, that's not why they're there. So it all begins first with the PPE. As Deborah and I were demonstrating, we're trying to practice social distancing, so keeping our employees away from one another as much as possible, but that's very difficult to do in a hospital setting. One of the things that we did last Friday is, well, the CDC didn't come out and mandate it or even strongly recommend it. We, on Friday, issued protective masks to every single one of our employees. And when I'm not on camera here, I'm wearing one myself. So all 5,000 of our employees were issued masks. Most of us, somebody like me that's in an administrative role and not a direct patient care role, I was issued just kind of a standard surgical mask, which is different than an N95 respiratory mask that would be worn by somebody that is taking care of a COVID patient or suspected COVID patient. So that provides added protection for all of our employees. And it really was triggered by, I guess, the revelation that scientists believe that as much as 25% of the infected population may be entirely asymptomatic, meaning that they could have the virus and exhibit no symptoms whatsoever, no fever, no cough, no respiratory distress, but they're contagious. And so it really, to address that, to make certain that I could be one of those people who's asymptomatic and feels just fine, but if I was to cough or sneeze on somebody or spit, speaking to them, and I was contagious, I could get them sick. So I really wear a mask now to protect other people. So that's one additional thing we're doing to protect our employees. Other things, I know certain employees that, when they go home, they go into their garages and they doff their clothes and leave them in the garage or wash them, collecting them to the side and putting on a fresh set of clothes when they come into the house. Again, just out of an abundance of caution. And then I think I might have spoke a couple weeks ago about a story I had read, two doctors on the front lines in New York, both with families. They weren't married to one another, but married with children and everything. And they were worried about, they were there on the front lines, truly incredible healthcare heroes. But they were worried about going home and potentially giving the virus to their families. So they decided to rent an apartment during the duration of the virus. And the two of them moved into this apartment that was right across the street from the hospital, and they were just going to gut it out and live there until the pandemic was over, and then they'd go return to their families. So kind of taking a cue from that, and we do have, healthcare workers that are similarly concerned, just like those two physicians in New York. So employees, say the 7 employees that have tested positive, may not be comfortable going home and quarantining with their family. And so we have been working with local hotels, the Marriott, Quality Suites, a number of them. In fact, I have a little flyer here that just went out recently, listing the phone numbers of the Marriott, the Holiday Inn Express, Comfort Inn Suites in Visalia, Comfort Suites in Tulare, Quality Inn in Tulare. Those are hotels that Cahuilla Delta has helped negotiate special rates for healthcare workers that want to be here near the hospital, still stay on the front lines, but to create that social distancing from their families to protect them more. Also, Airbnb is making homes and other dwellings available to healthcare employees at lower rates. And then we also, our Cahuilla Delta Sleep Center right now, where we normally do sleep apnea tests, it's closed right now, so we have 6 beds that we've made available to any of our employees or physicians that want to stay here and not go home. The Rotary Respite House, the Rotary is generously and without even hesitation has offered that to our employees and physicians to stay there. There are 2 housing units there. And then a number of community members offering up their RVs, their trailers, their motorhomes, campers, things of that nature. We have a beautiful motorhome that was given to us on loan from Country RV out of Fresno that's in the parking lot right next to our specimen collection site on Floral. But we have other motorhomes and similar dwellings that are being offered to us. So again, just the incredible generosity of the community just is overwhelming. I mean, it's actually, again, and I say it often, it's what keeps us going. I know our healthcare workers feel incredibly appreciated right now by the community, and just folks that are stepping up and just offering these kind of resources to our employees and physicians is just remarkable.
So let's talk about PPE. I know the last couple of weeks you have been concerned about our supply of PPE. How is that supply now?
Yeah, and it still remains a big concern, and I would imagine will continue to be a big concern throughout the entire duration of this pandemic. We are doing everything we can to conserve personal protective equipment, which mean masks, gowns, gloves, face shields, things of that nature. So we are asking our employees to reuse PPE that hasn't become contaminated, or that can be used for an extended period of time. So like the mask I was issued on Friday, I will wear it till it no longer is functional. I've been wearing it for 4 days. I will continue to wear it, and hopefully won't need to replace it before this pandemic is over. And then we've had literally, I think, a couple thousand cloth or homemade masks that have been donated by the community. Those are being worn by many of our employees throughout the hospital. I'll just commend you on your creativity. Some of them are pretty interesting artwork. So thank you to all of you out there. So as of this morning, I got an update on the current inventory of PPE we have. So today, right now, we have 42,575 N95 masks. We have 37,662 surgical masks. We have 7,902 protective gowns. Together, a little more than 80,000 masks between the N95s and the surgical masks. We have 2,800 face shields and 414 goggles. Now that might sound like a lot, but as I've shared with you in the past, under normal non-COVID conditions, we use 45,000 masks a month. So with only 80,000 and now taking care of a population that you don't know if they have the virus or not is really challenging. So we call our supply is not abundant by any means. It wouldn't even be considered adequate for the conditions we have, but it's not yet critical. So we're kind of in between where we call it reuse and extended use. But again, we continue to really appreciate folks that are coming forward, businesses, other healthcare providers that are donating masks to us, Harbor Freight, folks like that, just adding to our supplies. We greatly appreciate that. And we do continue to receive inventory through the county. So I think I read that the governor is prepared to spend up to $1 billion to acquire the necessary amount of PPE to support all of the 400-something hospitals in California. So if that comes true and the supplies start flowing more freely, then we'll be feeling a lot more comfortable here.
How many times can a clinician wear a mask, and is that safe?
Yeah, again, it really it depends on the circumstances. So on 2 South, again, what we're doing to conserve PPE is that the nurse will first start taking care of the patient wearing a mask, an N95 mask, a gown, gloves. When she's done caring for that patient in that moment, she actually will take the mask off, put it in a brown paper bag, remove the gown, put it, the dirty side, we'll say, to the door, and then step out of the room. We'll then put on their regular, everyday mask that all of us are wearing. But each time she goes back into that room for that same patient, she'll put that same gown and mask back on. So that's kind of the reuse, the extended use. And they'll do that until, if the gown or the mask becomes soiled, unusable, concerned about its integrity, then we would replace it at that time. So it really depends on the circumstances. So, if you're a unit secretary working on a nursing unit and you really don't go into the patient rooms, but you're out there in the nursing area supporting the team, you might be wearing a mask that you're wearing every single day that doesn't need to be replaced. But if you're going into those high contact areas, and again, especially if you have a COVID positive patient, we want to make certain that they have the right PPE and that it's changed out as appropriate. Now, you've been probably hearing about a number of decontamination techniques that are being pursued. One of them is ultraviolet light, that there's a belief, and some hospitals are doing this, that bringing the mask in and subjecting it to intense ultraviolet light for a period of time can disinfect the mask and then allow it to be reused almost essentially as a brand new mask. Then aerosolized hydrogen peroxide, things we pour on cuts and it bubbles up, and to literally aerosolize that around the mask is also another approach that's being considered, although it kind of leaves a film and a smell on the mask that people don't particularly like. So the one thing that we're very interested in that's being used at Stanford Medical Center is dry heat, where they are taking masks, both surgical masks and N95 masks, and essentially putting them in an oven at 170 degrees and putting in them there for 30 minutes. And they're a research hospital as well, so in their laboratory, they actually took masks that under a microscope, they had the COVID virus on them. They put them in the oven, did the 30 minutes at 170, took them out, put them back under the microscope, and there was no virus whatsoever. So that's a technique. The CDC hasn't come out yet and endorsed that, but it is a technique that they are using that we very easily could implement here, which again, depending on how this virus plays out in a surge in the apex, that could be something, if supplies continue to be scarce, that we would start doing.
Workers in grocery stores are not wearing masks, but they are wearing gloves for hours. Can they transfer the virus by touching object wearing those same gloves?
Yes, you can. And that's why the best defense against the virus is to wash your hands thoroughly and frequently, and don't touch your face, because the virus does live on surfaces. It lives on hard surfaces, soft surfaces. I've read that it lives up to 24 hours on cardboard. So yeah, when you go to the grocery store, you definitely, I still go, I grab things, I don't know who's touched them. I put them in my basket and I bring them out to my car, and then I have hand sanitizer in my car. I wash my hands really good. I don't touch my face. I generally will leave the groceries, in the trunk of my car, or if they have to be refrigerated, I will put them in the refrigerator and let them sit. We don't know for certain if freezing temperatures will kill the virus, or we know that it can't live, I think, above 150 degrees, but obviously you're not going to heat up your groceries to that. But just the constant hand washing. I think folks working in grocery stores now should be wearing masks. In fact, the CDC and others are now strongly encouraging entire communities to wear masks. And again, it's not so much to protect them, but to protect others. And so if every one of us took the personal accountability to want to protect others, so I wear a mask, I don't cough on people, I don't sneeze on people, I exercise very stringent social distancing to help protect my fellow human being. If everybody did that, the risk of exposure would go down significantly. So I think grocery store clerks should be wearing masks. I think people that go to the grocery store should be wearing masks, and that they should be, again, constantly washing their hands, being mindful not to touch their face. I do know that in some grocery stores, I think I saw at Save Mart the other day, that they now have placed plastic shields up between the customer and the clerk, just again as an added layer of protection for both the shopper and the grocery store clerk.
Talking about our supplies, what is our current supply of ventilators?
Yeah, so I think I've previously reported that we have 104 ventilators, of which 9 are pediatric ventilators. So I've been corrected. I wasn't very far off. We have 103 total ventilators, of which 7 are pediatric ventilators. So we have 96 adult ventilators. We currently have almost 30 that are in use. So that would leave, 66 that are in stock, unused right now, ready to go. So those 30 are in use right now for cardiac surgery patients that are intubated, for a period of time immediately after their surgery. Patients that have suffered serious strokes, patients with pneumonia, patients with other respiratory conditions or other medical conditions that they simply can't breathe sufficiently on their own, they're placed on a ventilator for whatever period of time is necessary. And we do have those patients that are in the ICU. I mentioned that we have 12 positive patients that are currently in the hospital. 5 of them are in the ICU, and most likely all of them are intubated right now and using a ventilator. So those are the ventilators that are in use right now. So that leaves us with those 66, which under normal conditions, that would be plenty. But we don't know how quickly the surge is going to come and what it will look like. When I talked about the analytical model earlier, it shows that when we reach that peak point, whenever that happens to be, and again, it really depends on the shape of that curve. But for, again, this 2-county area of Kern and Tulare serving a little over 1.3 million people, we would need 390 ICU beds and 368 ventilators. It's predicted that that's how many we would need just to take care of the surge of COVID patients. So when I talked about us having 96 adult ventilators and about 66 of them available, I do know Sierra View Hospital has some ventilators available, and the hospitals in Bakersfield would have some that are available. But collectively, we don't have anywhere close to 368. So when I've talked in the past about needing more ventilators, it's not that we need them today, but it's to be prepared for tomorrow. And how quickly tomorrow comes, we don't know. And so just like most hospitals across the state, we're all putting in orders for additional ventilators. A ventilator costs about $35,000 for a single ventilator. So they're very, very expensive. And once the pandemic is over, we would never need, a couple hundred ventilators. The supply we have right now is quite adequate to take care of our normal population. So for us to go out and purchase, even if they were available, to go out and purchase, dozens and dozens of ventilators, we just couldn't afford to do it. So we're really looking for the federal government and the state government to help procure ventilators for us. But as we've contacted all of our normal sources, they're simply not there. They're not available. And that's why you see a lot of auto companies, car manufacturing companies, other companies that are retooling their factories to be able to manufacture additional ventilators is to help increase the supply. I think somebody told me, interestingly, that Governor Cuomo actually made a comment yesterday or the day before that New York now has as many ventilators as it needs. We read that the governor of California, Gavin Newsom, has agreed to send 500 California ventilators to the national stockpile to then be distributed to states like New York and New Jersey and Louisiana to help them, because they're approaching the peak of their crisis. And so I understand why folks on the West Coast, Oregon and Washington governors have promised the same thing, that we're not near the surge yet. We may have 3 weeks before it begins to start. So send them back there for temporary use. They get over their surge, they cross the apex, and then they're sent back to us in time to meet the surging need that we have.
So Gary, there's a post on social media that contains an article from a public integrity organization. And that article implies that children and adults with disabilities such as Down syndrome and cystic fibrosis or et cetera, that those individuals will be denied access to ventilators due to their lower overall expected lifespan should they get COVID-19. Needless to say, there are a lot of parents and family members who are angry about such a prospect in our community. Does such a blanket policy exist in California and at Cahuilla Delta?
It does not, but these policies do exist across the nation. Some have been developed by the state themselves, but some developed specifically by the hospitals themselves. And they're designed to help healthcare workers make incredibly difficult decisions when you're in a public health emergency, when you literally are in a crisis situation where you have demand that far exceeds your availability of supplies and ventilators, things of that nature. And so you try to take healthcare workers out of the unfathomable position of having to decide, who lives and who dies, or who gets care and who doesn't get care. And so these policies are generally critical care and ventilator use allocation algorithms. And we are currently working on one right now. I personally am working with a group of physicians, critical care intensivists, palliative care physicians, emergency medicine physicians, nurses, on what a policy would look like here at Cahuilla Delta. A policy that you hope you never ever have to invoke, but you have to plan for the worst. You don't want to be having to make those decisions in the moment without, having trained your folks and really understand how to manage through it. So the policy and the algorithm that we are creating right now is a combination of one taken from the University of Pittsburgh in Pennsylvania and North Texas Hospital in Texas. I'm kind of taking a combination of the two. The one that we are most likely to adopt uses a scoring system, SOFA. So SOFA is the clinical evaluation or assessment that's done of a patient, and it looks at different conditions of the patient, and they receive a score based on that condition, and oftentimes they're then placed into a category essentially of survival. So they end up, depending again on the condition and the survivability rate, is low priority, intermediate priority, and high priority. And they don't include any references to the or factor in anything about the worthiness of anybody's life, or even life expectancy. It really is based on survivability of the virus. And again, looking at very quantitative, specific clinical measures that help a physician make that determination. So you would never exclude a child just because they had Down syndrome or had cystic fibrosis. You wouldn't exclude them because they had those conditions. Everybody would be treated, the same, that they would be eligible for critical care services that they would normally be eligible for. But in certain situations, somebody that had metastatic cancer and the survival rate was, incredibly low. You would have to make decisions like that when you just have, so many ventilators, so many ICU beds, so many physicians, that you have to be able to make those, again, incredibly difficult decisions. But anything that we develop will be very compassionately thought out and developed, and it will not take into account, the age, the sex, the quality, the perceived, societal value of anybody. It will be based purely on the conditions that the patient has and that survivability rate.
What is the current status of our in-house testing capabilities?
Yes, one of the more exciting developments for Cahuilla Delta, and I've been talking about it for some time. So a couple weeks ago, we secured test samples, test kits that run on a platform we call BD Max. And then just this last weekend, we were informed by Abbott Laboratories, one of the nation's largest laboratory companies, and this is probably the one you've been hearing about nationwide, about a new testing capability called ID Now. It was kind of purported to be a bedside testing kit, but we will actually run it in our laboratory. But we had been repeatedly told no, that we weren't going to get any testing kits. And then shockingly, surprisingly, we were informed by our representative this last weekend, that we would. So we have now actually received testing kits from both BD Max and Abbott. We actually, from BD Max, we received 360 tests this week, and then from Abbott, we received 960 tests. We also now have 13,000 nasal swabs. That was a concern about a week ago, but we got a very large shipment that came in. So we use that swab, and we use saline solution to then put it in a test tube and run it in one of the analyzers. So we now have quite extensive in-house testing capability. So working with our physicians, we've now developed a formal testing protocol that for all inpatients that are symptomatic, all physicians, employees, including residents that are symptomatic, that we will perform the test in-house using our own testing capability. We will no longer send those to the county or to any outside laboratory. That will allow us to obtain results much quicker. In fact, the Abbott tests that we receive the greatest number of testing kits will produce results in 30 minutes or less. So very, very important for us to know if we have a patient that is positive. It affects what kind of personal protective equipment we use and just the isolation techniques we use. And then also to be able to test a physician or a healthcare worker that may feel they were exposed or exhibiting symptoms, again, to be able to test them very quickly and quarantine them at home if they in fact do test positive, or the peace of mind to know that they test negative at that point. So we will not be testing asymptomatic staff, physicians, employees, residents. We will not test them if they're asymptomatic, just for the peace of mind, but that is why we are asking everybody to wear a mask, just in case they are infected but are asymptomatic. So we will only use the in-house testing on those populations that are in fact symptomatic. With respect to the public, we will continue to collect specimens on them for every patient that, every person that is symptomatic out there in the community. We will continue to work through the county to get the person under investigation number, and they'll continue to come to our specimen collection site, and we will send that specimen to the county to be run on its analyzer. And the county is turning things around rather quickly, generally no later than 24 hours. But the fact that we're going to take quite a bit of the burden off of them by doing this in-house testing should help the county with their throughput as well. So really kind of a win-win for our hospital and for the county as well.
In closing, would you like to say anything about the amazing support that we have had from our community?
Yeah, well first I'd like to just thank our amazing healthcare workers. The Cahuilla Delta family is unbelievable. I mean, you know, we use the term hero often, and heroes are defined in many different ways, but universally, around the entire world, the healthcare workers, the physicians, the nurses, all the clinicians, the EVS workers, the dietary workers, everybody throughout the hospital that is just selflessly putting themselves on the front line, living the oath they swore to take care of people is incredibly inspiring. It's moving. It makes me so proud to be a part of this organization. So first and foremost, I want to thank them. And then again, I'll never miss a chance to thank this community for the outpouring of their encouragement, their words of support, encouragement, the text messages, the emails, the thank you notes. I think early this morning, I might have signed close to 300 thank you letters to all of the hundreds of individuals and businesses that have donated to Cahuilla Delta, donated money to buy supplies or to buy food for our healthcare workers, individuals donating food, restaurants donating food, people making masks and gowns and shields. I don't think I've ever seen a 3D printer. I don't know what they look like, but they're pretty amazing what they're able to do. I actually last week got to see a box full of face shields that were made by somebody locally here that has a 3D printer. But it's been the outpouring of love and support has just been phenomenal. It just makes you really proud of our community, and just our gratitude to all of you for supporting us during these difficult times. I say often that you're the ones that give us the energy to come to work every day and to still keep a smile on our face, although you can't see it anymore because we're all wearing masks, but maybe you can see it in our eyes and know it's there in our hearts. So thank you.
Gary, thank you so much for taking the time to sit down with me today. These are crazy times, and as an employee, I am so glad that you are our leader guiding us through this chaos.
Thank you, Deb, and thank all of you.